The title that Julian gave me here was Outcomes Publication, Why and Where Next. And what I want to try and cover over the next little while is the experience in cardiac surgery and why that experience is transferable. I accept the comments which were made about the ease of the outcome measures, but I think the principles are generic. To speak a little bit more about the Everyone Counts initiative, because I'm working for HQIP on helping to deliver that, and then just finish up with some of the wider context issues which are related to this. So we've thought this through quite hard over time, and it would be nice if the cardiac surgeons and Bruce and others can say we did this all willingly. But the reality of this, and I think Bruce will agree with this, is to some extent we were held to account for delivering on this. We were going down this route in a very leisurely, gentlemanly kind of way, but a series of interventions by the media really held us to account for delivering this. And because we knew it was inevitable, and Bruce referred to that earlier, we had to get it right, and we had to think fairly hard about exactly the way that we do this. So this is the way that I think about this now. You have to define an outcome, you have to set a standard for performance, you have to decide what sort of reasonable variation and what's unreasonable variation from that standard. You need to get the data right before it goes out into the public domain. But actually, you do then need to go through a rigorous process of notifying outliers and publishing it. And that publishing thing, I think, is really important. So this is obviously a multi-agency approach. And in this, you've got issues about defining those standards. You need an infrastructure to measure to those standards. You need to define the unacceptable variance. You need to look into things when mortality rates are high, and it's already been alluded to the possible reasons for that. And at some stage in this, you might need to make judgments about this. So we believe that the only people who can make good judgments on setting standards is the professional societies who understand that particular specialty. And I believe you can only do that in conjunction with patient representatives who can actually speak from their perspective. In terms of developing the infrastructure, some professional societies can do this on their own, some need help. And for these 10 audits, which are going out over the next week and subsequent months, there are a bunch of different audit suppliers, some who are very skilled in delivering on this agenda. In terms of the defining unacceptable variation, again, HQIP is supporting this by putting some generic principles out there, but it needs to be professionally society-led, in my view. But then if you get to the next stage in this, I think other agencies need to be involved in this, up to and including the GMC. And again, the trusts have responsibilities as employers. The college have a role in this in terms of investigating things, and the GMC ultimately are the only people who are able to make judgments about whether doctors fit to practice. So in terms of defining unacceptable variation, I think all these are generic principles, so you need to adjust for case mix. And I think the most important reason for that is exactly Norman's point earlier. There's a big difference between somebody who's had 6 previous abdominal operations and somebody who's had a first-time operation. And if you don't do that, there will be a tendency for surgeons to turn down the highest risk cases, which is in nobody's best interests. You need to calibrate for contemporary practice. There's no use in comparing my performance today with a standard which was set 10 years ago when the pack has moved significantly over that period of time, and we understand how to do that. No matter how sophisticated your risk model is, there are some patients who you cannot adjust for, and we accept that now. Emergency and salvage in our world is a very small proportion, so we take those out of our governance analysis and we report them in a slightly different way. And for every audit, there will be some people who you cannot adjust for risk for, and that needs to be understood. We use the funnel plot methodology, and there's some fancy statistical stuff which I won't get into today. But Norman's been over this before, so I'll clip very quickly through the funnel plot. So we've got risk-adjusted mortality rates we have on the x-axis, the volume of cases on the y-axis. The national mortality rate is the black line that goes straight through the middle of it all. We have various control limits, and we think it's reasonable to put a sort of an early warning system in there. So we have an inner funnel plot, a sort of moderate and a sort of more definitive line, and we have slightly different policies depending on what sort of outliers people are. And then each of these dots is a surgeon. So those represent the 270-odd cardiac surgeons in the UK. And again, just very quickly, when you have somebody, you shouldn't jump to any conclusions about their practice. There can be very clear reasons, data quality issues, case mix issues, organisational factors leading to bad outcome, or individual factors. And you need to work through that pyramid to try and understand where any problems may be. So when we publish this data, all the data is validated with the units. This is an iterative process, and it's quite complicated. We've been doing this for quite a long time. You'd have thought it would be easy by now, but it does take a little bit of a while and a little bit of management, and there's experts in the room on managing that process. And then we also think it's important when you publish this, you put it alongside other patient-focused information. I don't believe we've got that quite right yet in cardiac surgery. We need to think again about that, because I think some of the data we've got out there is good data, but I don't think we've contextualized it quite right. But the key to this, I think, and this is probably my most important theme here, is that the publication drives complete compliance with these audits. The only thing that got all units submitting data was the publication of this back in 2005, 2006. It drives data quality, and it drives action on outliers, which we know wasn't happening before. And I think we saw that in cardiac surgery over the past 5 years, which is why I'm so supportive of this wider initiative. So this is my waxing lyrical slide. There's just one slide. I have more, but this is just the one that I've got. So the red line there is the predicted mortality in cardiac surgery in the UK. Sorry, it's cut off my x-axis there, but that's 2001 to date. So year on year, there's a relentless increase in the risk of patients coming to cardiac surgery. That's not anything due to gaming or surgeons manipulating the data. That's because we're doing more old and complex people year on year on year. And the black line there is the actual mortality, which is going down year on year. And that means that the mortality in the UK in 2012 was 1/3 of the mortality in 2001. And if you were to invent a drug which would do that to your mortality rates, you'd win the Nobel Prize for it. But that's the magnitude of the effect that we're seeing from this program. I think Maury's going to speak in more detail later about some of the reasons for why that is. And actually, I think to some extent we don't understand exactly why that is, which is almost more important to make this program ubiquitous. So we publish that for patients. This is our website where people can go and look at all the outcomes. So you can search on a region, you can pick a hospital, and you can find the outcomes for that. So this is just hospital-level outcomes, the case mix of what we do, coronary artery surgery, mitral surgery, aortic valve surgery, and the risk-adjusted mortality. And I'm not sure how well you can see that at the back there, but we put the control limits in about the reasonable scatter, but we also put each of the dots in, because what we think is that actually people have a right to see how a unit performs compared to the other units. And so all those dots are hospitals, and the green dot is one of those hospitals. So moving on from there, I think, there is some other stuff which I should just probably briefly mention, is that we got some data from the UK that actually this program has been associated with putting our mortality rates significantly better than European standard. And also that actually this program has been associated with reduced length of stay compared to European standards. So there's some quality, international comparison quality benefits from this, and also some potential international quality resource utilisation benefits from this. So off the back of this, the announcement comes from the government through NHS England that surgeons' data for these 10 specialties will be out by the summer, as Norman has described. So just a little bit of the specifics on that. So HQIP have been tasked with supporting that role. This is a complicated thing. This is by far the most complicated thing I've been involved with in my professional life, and very interesting and challenging for that. And these are the various people who are involved in that. And what we haven't really put in here, and I thought about changing this diagram on the train on the way down here this morning to put trusts in, but then I thought I'd leave them out, because actually in many ways the trust is the most important bit of this whole thing. So I thought rather than sneak it in somewhere on the diagram, I'd just make that point. None of this works unless trusts are working with this data to drive and assure quality. So the plan is that the data to be published comes from the existing registries, which were either thought to be fit for purpose on Bruce's envelope, or were thought to be able to be made fit for purpose. And I think we've seen that that's happened. And that this process would be a collaborative process, which would be led by the profession, alongside the audit provider, supported by HQIP as required. Some audits have required quite a lot of support, some audits haven't required very much. And that sort of professionally led thing has some advantages and some disadvantages. We're not dictating centrally exactly how this should happen. We're saying, you're the people who understand this, you do it in your way. And I think that's the right thing to do. I think that engagement is the essential part of getting quality change at the end of it all. But it does raise some challenges also, which we could talk about maybe in the question and answer session. So all audits now have confirmed their outcomes, their audit period, the way in which they're going to present the data, the project timelines, and we're getting right towards the end of that. We've given some additional financial support to help people get over the line on this one, and also some support in terms of how this will come out through the various different internet sites in various different formats. So again, getting onto the consent issue, the best practice is that consent is gained for individual surgeons, and I have been amazed quite how positive the response rate has been from the surgical and cardiological community. It's sitting at over 96%. I think that's good. We've tried quite hard to do it from our end at HQIP, but I think the key to this actually has been some of the college initiatives in terms of saying that they think this is the right thing to do and encouraging people to take this forward. People who do not consent to have their results, non-responders will be published, and we've told people that. Those who don't consent will be named with an opportunity for qualification in a structured way. So we won't be putting their data out there as it stands of today, but we will be putting a list of the people who do not give their consent, and we will give those people an opportunity to give the reasons for why they don't consent, because some of those reasons will be very legitimate, and we think it's important to stimulate a wider debate around those issues. So in terms of the hosting, we've recommended hosting on the professional society websites. They have the knowledge base. They can contextualize the information. They know its limitations. They know its strengths. They're also able to put it against other patient-friendly information. But this will also, is expected that this will be published on trust websites also, and also on NHS Choices. So the 7 audits we think are going to go live next week. The remainder will go live by the autumn. This will be all signposted from NHS Choices. We will disseminate over the next few days links to the trusts so that they can signpost from where they stand. And there will be quite a lot of media attention on this, which will come from NHS England, the college, and the professional societies. So my preliminary observations on the last few months of this is this has led to a massive focus on energy from professional societies and audit groups. I think it's been terrific, the stimulus that's been put out there and the way people have engaged with this in a predominantly positive manner. I think that the messages which have been coming out from the college, I think, have been excellent. I think there's been excellent leadership on this one, and I think without that we wouldn't be where we are at the moment. I think this has led to marked improvements in many of the structures of the audit, and I think it's led to massive improvements in data quality over a very short period of time, and I think that puts things in a very good place going forward. It's also driven this whole outlier analysis thing. People are now defining outliers, are notifying outliers in a way which they haven't done before. And overall, I see this as a massive step forward. It's not the end of where we're trying to go, but it's a very, very big step forward from where we were maybe 3 months ago. And again, what we're seeing, I think, from this initiative is exactly the same thing that we've seen from cardiac surgery. And this publication drives complete compliance, data quality, and action on outliers. We do not know, and the Achilles heel of this, in my view, is that we do not know at the moment who is doing this stuff and isn't contributing to the audits. And that, to me, is a very important next stage in understanding that and closing that gap. So, briefly, the sort of wider context of this, obviously this data will feed to organisational regulation. It is my view, and I don't think I'm at odds with Bruce on this, that actually hospital mortality rates have a place, but actually I think what has more of a place is actually performance metrics for teams and individuals working within that organisation. This has a place in professional regulation, and I think the whole thing is driving a cultural change towards much more patient-focused care. So everybody will have read the mid-staff's report, but just to bring out some of the key themes in that, professional bodies should be fully involved in the formulation of standards and means of measuring compliance, which is exactly what we're seeing at the moment. It should be considered the duties of specialty professional bodies to develop these outcomes. It's exactly what we're seeing at the moment. People should work and develop systems so that you can monitor your practice better. That's what we're seeing from that. And to the extent possible, this should all be published. So different from what happened after Bristol, where these recommendations weren't actually being realised, we are seeing these things being realised within a very short period of time after the events in mid-staffs were fully reported. Just coming briefly touching on revalidation, which I think both Bruce and Norman have mentioned. So this is obviously, what you get if you go to the GMC website about me, and we now have to go through the whole process of revalidation, and this is a rigorous process. Medical directors will have to make a positive statement. And one of those issues in there is, do you have any addressed concerns about a doctor's fitness to practice? And I don't think you can make that statement as a responsible officer unless you have information from a national clinical audit which demonstrates that your outcomes are satisfactory. So in terms of the different statements that a responsible officer can make, they're as described there. So the vast majority of surgeons in the country fall well within the funnel, and you automatically have data on clinical outcomes to be able to make that positive recommendation. There are obviously other domains that you need to look at too, but in terms of clinical outcomes, there's a lot of positive information there. There are some people who will fall outside the line, and you might need to look at these in more detail through an appraisal cycle and try and understand those issues and resolve any issues that there might be with respect to performance. And then obviously there are some people who fall outside the funnel, and I don't think you could give a positive recommendation unless you had a deep understanding of why those things weren't related to some kind of issue. Okay, so coming back to one of the points which Norman made earlier, which I agree with, is it's easy for cardiac surgery. I don't think it is easy for cardiac surgery. I think it's possible in cardiac surgery, but I actually think it's possible in everything that we do. And one of the things we've been looking at in more detail recently is moving away from just looking at clinical outcomes to looking at patient experience also. So we've been piloting some ways of measuring that in conjunction with PICA and South Manchester, which I think is a ubiquitously cascadable principle right across medicine, and maybe very important in some specialties who can't easily measure outcome stuff. I think Julian's going to say a little bit more about that later. The other thing I just wanted to put in here is once you get an audit, like the cardiac surgical audit, and you get it to a place where the data quality is good, adding value to it is relatively straightforward. So what we've done in a pretty cheap web browser format is we've produced some search fields in front of that where you can go in and you can produce a report on outcomes for a hospital, for a group of surgeons within a hospital, for an individual surgeon, customizable by the time window you want to look at and the operative group you want to look at. And that rapidly produces reports. So there's no excuse for people not knowing exactly what their performance is on anything at any particular time, which fulfills Bruce's requirements for people to know what they're doing and how well they're doing it. And again, once you've got the audit data in some reasonable format, that is a very straightforward thing to do. South Manchester have gone ahead and published this data. So we published data for cardiology, cardiac surgery, thoracic surgery, EP cardiology, sort of proactively. And what we've done is we've put the activity, the outcomes data, and the patient experience data out in the public domain alongside one another. Final two slides now. Is what we've also done is we've written these big blue books. Bruce wrote 5 of them, I wrote 1 of them. Which were basically professionally led reports to the profession, which had a wider interest. But for the first time now, we've thought, well, maybe there's more interesting stuff in this than just pointing it at the profession. So what we've done is, this is our first effort at doing this, is we've tried to rate a patient-orientated blue book, accepting there's multiple stakeholders for this data, of which the most important is the patients. So we're now trying to put those kind of messages out there. And what I think we've seen from the last 10, 15 years in cardiac surgery is a cultural revolution whereby we're looking at it in a different way. We're not looking in towards each other as care providers anymore, but we're looking out more towards the other people who are involved in the world, which we live in, the most important thing being the patients. So finally, we're also trying to add further value to this through various things like apps, so people can actually have this data at their fingertips in real time to help support clinical decision making. So this is not just about regulation, this is about supporting decision making and driving quality improvement. And this is something that we've been experimenting with also, which is the kind of concept of applying smart tools to this. So this is Google Charts, which is free source software, where you can look at the changes in risk-adjusted mortality over time. So you can select the various axes. So the y-axis there is risk-adjusted mortality rate. The x-axis is the volume of cases. You can flag a hospital, so that's my hospital flag there, and you can start to see the way in risk-adjusted mortality changes over time. So what you get a real good idea of is the sort of natural cause variation, if you like. Things go up and down. You have good years, you have bad years. But what you also see is some of these characters coming out of the pack going up and having a mortality rate which goes high. So we hope this kind of approach will be useful. And the reason for making this point is Bruce is putting £14 million into national audit, but actually adding value to that audit once data quality is satisfactory is very cheap, and that is free. This is just another way of looking at it. And actually, every time we start on one of these projects, by the time we finish it, we find we do it in a different way in the future, because the whole acceleration of some of this sort of technology stuff is great. So this is just showing that stuff in a different way. So our data analyst said it took 6 months to clean the data, and it took him 2 hours to put this in front of it. That's the kind of thing we're talking about here. So finally, just my summary of this is that we have had this journey over the last 15 years to be things more transparent, which I think everybody pretty much in cardiac surgery is comfortable with. This has driven quality. It does act to maintain public trust in the profession, which I think was particularly important in cardiac surgery after Bristol. I think it does drive a patient-focused agenda and is driving this cultural change. And I think all those principles are cascaded right across the 10 specialties which are going to go live with their data. But as Norman says, I think are cascadable much further out than that. Thank you very much.